Good morning, everyone. I'm Dr. Tara Kiran. I'm a family doctor at St. Michael's Hospital and also the Vice Chair for Quality and Innovation at the Department of Family and Community Medicine at the University of Toronto. I'm delighted to welcome you to our community of practice, which we co-host with the Ontario College of Family Physicians. I'm going to turn it over to their president, Liz Muggah, to give an introduction. Liz.
Thank you. Good morning, everyone. And just following up on Tara's comments, really happy to be joining all of you today on this October morning. We've got two great panelists who will be familiar to you, so they will introduce themselves, but really looking forward to hearing from Allison and Jeff. And David also speaking on some of the system level questions around ILI and what we can do in our offices. This is Main Pro accredited. You'll get that mailed to you, emailed to you, the details about that. All right, thanks, Brian. Here, I'm going to read the land acknowledgement. We acknowledge the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and the DFCM recognize that the many injustices experienced by the Indigenous peoples of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories you are calling in from as we commit ourselves to gaining knowledge and forging a new culturally safe relationship, contributing to reconciliation. Tara, I will hand back to you.
Liz, I know many of us had a chance to reflect on past injustices perpetrated towards Indigenous people on the first ever National Truth and Reconciliation Day. If you haven't seen it, this is a fantastic article written by my colleague, Dr. Suzanne Schuch, that came out that day. And, you know, I think goes into detail about how many lives were affected in Indian residential schools. And it ends, though, with some hope and action. So, you know, hold on to your anger, but also use that anger and translate it into action. And one way you can act is by donating to Indigenous organizations, and she gave a list here of some that she recommends, but there are of course many others in the province. So I hope that you are moving towards action wherever you are. Next slide. Thank you to our planning team that puts this together. We have many different past sessions up for view at our link that we've shown there, and this one will be as well. Watching these past sessions is Main Pro accredited, and we want to get your feedback on what we should have on future sessions. So please do fill out our evaluation at the end. Next slide. I'm delighted to have our panelists join us today. As Liz said, these are panelists that you're familiar with, and they're going to bring a whole range of expertise. Next slide. Allison.
I'm Allison McGeer, Infectious Disease at Sinai Health System. And as you can see from the list, a lot of relationships with both vaccine developers and antiviral developers.
Yeah.
Hi, I'm Jeff Kwong. I'm a family doctor at Toronto Western and also a scientist at ICS and Public Health Ontario. I have received grant funding from CIHR, and also I forgot to list their Public Health Agency of Canada to do my research.
David?
Yeah, I'm David Kaplan. I'm a family doctor in North York and receive honoraria from the OCFP and salary support in my role as Vice President Quality at Ontario Health.
Liz?
Yep. So Liz Muggah, I'm a family doctor in Ottawa, and I receive a stipend for my role as the president of the Ontario College.
And I'm Tara Kiran, and I've just listed here some of the places where I've received grant funding or a speaker's honorarium or salary support. And the only one that's for a for-profit corporation is Gilead Sciences for a hepatitis C project. Next slide. Welcome to all of you from all across Ontario. It's always exciting. And I just wanted to let you know that, we do take the questions you submit at registration very seriously and design our program around that. So today we are going to be focusing on three things. We're going to have Allison walk us through the latest on flu shots and what we know from about flu season from other parts of the world. We then are going to have David talk a little bit about, what do you do now that's cold and flu season? How do you handle that in your office? And then we've got Jeff talking about what's the need for third doses, what's the need for boosters, and some amazing new evidence that he has put together. Next slide. Just a reminder that We also, though, want to keep this interactive and answer your questions. And so we usually have about 600 to 900 people join our call. So please do use the Q&A function to put your questions in. If you see another question there that is similar to yours, instead of typing your own, please just use the thumbs up mechanism. So I'm going to be prioritizing the questions that get the most thumbs up. And then some of our panelists will answer them by typing, and a few of them will, the most popular ones, will answer live as well. So please do use the thumbs up function and take a look at the answered. And then, of course, after the webinar, we also do post a summary of some of the top Q&A that you can take a look at from our website. Next slide. So without further ado, I'm going to turn it over to you, Allison, to get us started to talk about flu season.
Thanks very much, Tara. And, you know, normally when I start talking about flu season in October, it's with a sense of trepidation, but today it's with a sense of thankfulness, because if we're talking about flu, it means the pandemic is getting better. So the fact that we can even contemplate thinking about other respiratory viruses is good news, because it means that they're starting to spread because public health restrictions are going down and because they're not completely overwhelmed with COVID. So I just want to take a minute to say thank you to everybody for getting this far during the pandemic and for sticking with it. It's not going to be an easy next 3 or 4 months, because it's going to take a lot of sort of care and bravery and risk adjustment to get past the pandemic. But we really, you know, the end of the pandemic is in sight now, not close enough, but definitely getting better. Okay, so let's talk flu. This is a graph of all of the flu surveillance for the World Health Organization, dominated by labs in the Northern Hemisphere. So you can see the season start at January, where the year marks are. And in 2020, when we go into lockdown and we stop travel because of COVID-19, flu just disappears, completely vanishes. And for about 9 months, there's absolutely nothing. But what's worrying people now about what's going to happen this year's flu season is this little bit of an uptick coming at the end of 2021. And the slide below shows you what it actually looks like. It is hard to judge because we're doing a lot more respiratory viral testing than we used to do, and that might be partly why it looks like something. And certainly in North America, still very few influenza viruses, much less than we usually see. But if we continue on the pathway we're on, if we continue to reduce restrictions, we're probably going to have a flu season this year. And so we'll be back to having to deal with flu. What about other respiratory viruses? Whoops, sorry. Next slide. Okay, so these are the 3 respiratory viruses that we're seeing the most of at the moment. The rest of them still don't look like much. On the bottom left here, enterorhinoviruses, and the gray bar is the averaged 5 years before the pandemic. The blue dots are the activity in 2020, and the red line is the beginning of the activity here. Virologists are weird people, okay? We start our year in week 35, which is the beginning of October, because it's always the winter season. And you can see that enterorhinovirus activity at the moment is tracking just like usual. Lots of colds in schools, which we routinely see messing up our COVID testing in our lives, okay? General truth. And back up to significantly more activity than last year. On the bottom right, you see parainfluenza virus, and you can see that parainfluenza virus activity was way down during the pandemic. But as we released restrictions this summer, the activity started to come up to normal. And it's if we're having a shift in activity. Usually we have paraflu activity at the end of summer and the beginning of fall. And we saw less of it. But now in the red bar here, you can see we're seeing more of it happening. And on top is respiratory syncytial virus. Respiratory syncytial virus is academically really interesting because we've clearly shifted RSV activity in countries around the world in ways that we actually don't understand all that well. In Canada, we've had very little of it until recently, but now you got to squint to see the next slide, okay? Assuming, okay. So this is Canada's flu watch map. of different respiratory viruses in different provinces. Okay, so this is all the RSV in weeks that go up to week 34. Again, we're switching to week 34 and 35. It's a new year. Sorry to do this in the middle of RSV because you can't track it. And what you see is that so far, for no obvious reason, the only place that's really having a lot of RSV activity is Quebec. It actually started in the Montreal region and now it's spreading outside of Montreal. And you can just see, if you look at Ontario, that there's beginning to be some activity in Ontario. And last night, the week 39 came out, that's not on this graph, and you can begin to see a little bit of uptick activity in British Columbia. So it does look like we're going into an early RSV season. And if the experience in Australia is anything to go by, we'll probably see a significant uptick in activity and a period of a month or two where there's more RSV than usual before it settles back down. So the sum of respiratory viral activity is really, it's going to be a dog's breakfast until March, okay? Because respiratory viruses have been pushed by our public health measures, and they're coming back at various times and as various shapes, and it's going to be a little bit unpredictable this year. Okay, now flu. And these slides are thanks to Jonathan Gabay and Michelle Murphy at Public Health Ontario. And they have a PHO presentation on influenza. If you're interested in more information, it was 10 days ago or so, which means it should be up on the PHO website soon so you can look at it. Here's our vaccine composition for this year. No change in the influenza B viruses. We've changed influenza A viruses, and now you've got to accommodate egg-based vaccines and cell-based vaccines, and the characteristics of the viruses that grow well in those, in the prep for those is different. So now you have to accommodate the fact that there's going to be a different seed strain for cell and a different seed strain for egg vaccines for a while. One of the problems with this year's flu season is we are having some difficulty knowing what's going to be active, right? Remember that usually we predict how the virus is going to evolve by watching what's happening in the Southern Hemisphere. And the Southern Hemisphere didn't have a flu season. We just don't have enough influenza viruses to look at to be confident of where evolution is going. So there is a risk of mismatch this year that we're just not going to know about until we get into flu season. There's a couple of small changes to the EOIP for flu vaccines this year. Here's what's going to be available. And I appreciate the fact that it's a little bit frustrating that there's so many different products available and you have to accommodate for different years. So it's really valuable to remember as you're struggling with dealing with this, that we need to have a number of different suppliers of influenza vaccine. We've been doing well for the last decade with not getting into trouble with plant closures and other things, but it's not necessarily going to last. So it is, in fact, critically important that we keep a number of suppliers open. And so as we switch from trivalent to quadrivalent and egg-based to cell-based, the next few years of flu vaccine is just going to be a lot of moving around. Okay, next, the differences for this year. Flucelvax Quad, which is our first cell-based vaccine. Whoops, sorry, I've gone too far. Is now available down to 2 years. Last year it started at 8 or 9. Afluria Tetra, just to remember, is the vaccine that causes fever and febrile seizures in younger children sometime, and so it's restricted to 5 years and over. And this year, for the first time, the government's supplying adjuvanted flu vaccine for older adults. The reason for the shift is that although Fluzone High Dose is the only one that has a randomized control trial that demonstrates effectiveness, the last 2 or 3 years of use of Fluad in the United States, it looks like Fluad is pretty close to equivalent to high dose quadrivalent in terms of the additional effects you get in older adults, and it's much less expensive than high dose at the moment. So this year there's going to be a mix of Fluad and high dose trivalent for older adults, and it really doesn't matter which ones you use. Better if you can use one of those than quadrivalent, but again, never miss an opportunity to vaccinate. You've got to give standard dose vaccine to older adults. That's okay too. And lastly, for the new NACI recommendations, NACI was waiting for the first data on mixing and matching vaccines before it made its decision. But NACI has now said that COVID vaccines can be given concomitantly with or at any time before or after any other vaccine. So all of the restrictions on concomitant administration of vaccines have gone now. And that is a deliberate statement about, next slide. Yeah. The fact that we do have some data, don't look at the slide, just recognize that all of those bars cross one, and that when you mix and match the viral vectored vaccine and the Pfizer mRNA vaccine, you don't see significant differences in reactogenicity. You don't see significant differences in immunogenicity. This is second dose mRNA or ChAdOx and flu vaccine for this year, different flu vaccines. It's okay. Okay, don't miss an opportunity to vaccinate. Try to make up for the vaccines that have been missed during the pandemic with both shots. So it feels a little late coming to NACI. It would have been nice if they had decided beforehand, but it's not unreasonable that they wanted some data to be sure that they could justify that decision. Thanks.
Thanks so much, Allison. I think, Brian, you can stop the slide for a bit because I'm going to just take a couple of questions also from our audience. So that was really enlightening. And as you've been talking early on, it's also clear that many people have questions about the COVID vaccines. So that's obviously still on so many people's minds. So I'm going to just ask a few questions now. So Vanessa Morley asked, I'm having patients indicate concerns about changes in menses with the vaccine. Specifically, a 12-year-old had menarche 1 to 2 weeks following her vaccination, and her mother now has concerns about her 10-year-old daughter having the vaccine, anticipated she will be eligible in the near future, and what can I tell this mother to reassure her?
I think the expert consensus is that there may well be some disruption in periods that goes with the vaccine. It's really hard to separate whether it's some physical effect of inflammation with the vaccine. We don't have a good theory about the pathogenesis of it, if it's real. We also know that the general stress of the pandemic and all of the changes are likely to make significant changes to people's periods as well. So far, we've not seen any effects on things you can measure, okay? Things like fertility that you would think would be associated with changes in women's hormones, nobody can see any difference in. And it really does look like if there is an effect, it's a short-term effect and not important. But there's no, unfortunately, there are no absolute answers to it at the moment. However, again, we've not been able to find anything, and we do know that COVID is bad for you, right? There's all sorts of things you're avoiding. I think any of the I'm on thin ice because I'm not a pediatrician, okay? I don't do medicine for adolescents, but I think people will tell you again, it's not just about the risks of vaccines. It's about balancing the risks and the benefits, and the benefits of vaccination for 12-year-olds are clear. And so the reason that NACI and the CDC are not worried about it is because when they're looking at the risks and benefits, they're still saying, yes, there may be some changes to menstrual periods, but it's not important enough to be balanced against the benefits of the vaccine.
Thanks so much, Allison. I note that there are also, so Alan Grill has asked a question about boosters, and Alan, I'm going to wait to ask that question until after Jeff has spoken. And then Val Rackless has asked something that's somewhat related to, but I'll ask this now, which is, what do we know about the demographics of those getting COVID who are fully vaccinated? I don't know if Jeff or Allison or David, you're able to speak to that.
Yeah, so I think we're among vaccinated people, first of all, a bunch of the hospitalized people are incidental identifications, okay? They're people getting screened when they come in. The evidence from the States is when you look at people hospitalized and vaccinated, nearly half of them are people who are not actually in the hospital because of their COVID. They're people who test positive for COVID because they're getting screened on admission, or they have COVID and something else. Same thing we're seeing in kids. Beyond that, what we're seeing is much older adults, again, so what you would expect, people who are 80 or 85 or 90, people with significant immunocompromise, so the people that we know don't respond well to vaccines. And again, we're mostly, right, what we're seeing is people who don't have adequate access to vaccines. We haven't been able to vaccinate, so still that really big shift to inequitable vaccine access and disease in racialized people and Indigenous people.
I put a link to the PHO report for in response to Val's question.
Thanks, Jeff. So the next question is from Nessia Jacob, and I think, David, you mentioned you might want to answer this one. So please clarify the indication for rapid versus PCR testing in symptomatic individuals. I now have patients calling with flu symptoms who say they have done a rapid test from work at home, which is negative. Is this sufficient to rule out COVID, or must PCR testing be done? And I will just say there are actually quite a lot of questions about testing, and our next session in a couple of weeks will be focused on testing. So, but we'll take a few of those questions today. Yes, David.
Sure. So I actually have a slide about this and what I was going to talk about, but these were actual reminders. So thank you, Nessa, for bringing it up, because I thought it was important, because I'm getting these questions too. So a couple things. So antigen point of care testing should not be used. This is based on the provincial guidance in Ontario as of the end of August, and I'll post the link to the guidance. But antigen point of care testing should not be used to test for COVID infection in any symptomatic individuals or in individuals with a known contact with a COVID-19 case or an outbreak. So if you have a symptomatic patient who wants to be seen in the office, you should consider, depending on what their signs and symptoms of COVID are, molecular PCR testing for that person. And of course, you can use your clinical judgment. I mean, if you have a child who has a sibling who already has a throat positive strep throat, they probably don't have COVID as well, and you probably could be good enough in treating that strep throat in the sibling. So consider local epidemiology, other exposure risks, but antigen point of care testing not in symptomatic patients. They definitely need to have a molecular test. And I'll just remind people that serology also shouldn't be used for screening or for the diagnosis of acute COVID infection, determining immune status or vaccine status. And like I said, I'll post the guidance link in the chat right now.
Thanks, David. I actually wonder if we can just pull up David's slides, Brian, because this might be a good transition.
Sure.
I think, so you answered Nasty's question. There are a couple of related questions as well. Just, some Zin Chong saying, do you have a brief summary of the different antigen test accuracy and the difference with current antibody tests, which I think is similar to what you've just been talking about. And then, and then Suzanne Singh said, can you comment on whether fully vaccinated against COVID-19 with minor symptoms, like runny nose, sore throat, need to stay at home versus require a COVID test?
Yeah, I will. I'll address those as part of my talk.
Great.
I just put the two links to those two questions, the two first questions in the chat. Thanks so much for giving me the opportunity to chat about this. Go to my next slide, Brian. So the first thing what I want to do is say thank you to on behalf of Ontario Health, and I can't speak on behalf of the government, but I'm sure they would say thank you as well to our family doctors and nurse practitioners and others for seeing patients. We are well back at the percent of patients that we see, total volume. This is a slide looking at the 5 regions across the province in the breakdown of the percent of people seen in person. So you can see there's quite a difference. So I think we all have some work to do, but overall in the province, about 55% of all visits are being seen in person for the most part. Next slide. So again, thank you very much for all the work that you've done and you continue to do. So I'll have you go to the next 2 slides. Maybe I don't think that we need the next slide. We can just go right to the next one after that. Perfect. So we thought it was going to be very important to let primary care know now in the fall of 2021 what are the system expectations of primary care? And so we tried to really, narrow it down to three things. See people in person. Like I said, most of us are doing that. 75% of family doctors in the province are seeing 50% of their patients in person. Resume and continue non-COVID care activity. We know there's a significant care gap. We know just from looking at something as straightforward as malignant breast cancer, we are not seeing the same amount of malignant breast cancer pathology slides like we usually would. And we haven't for 18 months, but even now with vaccines and people going back to screening, there's still a huge amount of women who are really walking around with malignant breast cancer that haven't been identified and haven't had their surgeries yet. So it's really important to see people for acute issues, screening, chronic disease management. And the third thing is to manage influenza-like illness. And that means different things depending on, and you'll see in a minute where you practice, both from the standpoint of your own physical plant, but also where you practice in the province. And then where there's local need and capacity from us as primary care, an additional priority could include, and it's not a should include, it could include, if you have the resources and capacity to do COVID testing, assessment, and vaccinations, and you should be in collaboration with your local public health unit and your Ontario Health Region. Next slide. So just a reminder that the CDC says an ILI is a temperature of 37.8 and a cough and or a sore throat without a known cause other than influenza. And at the same time, and I'll post this link in the chat as well, I want to remind everybody that if you're still having access issues to PPE, you can order them online. You can also order swab kits for your office if you're in an area of the province where your patients don't have good access to COVID-19 testing. And you can also get rapid testing. And again, the rapid testing is not for symptomatic patients, but rather you may want to use it, for instance, for your staff or for asymptomatic reasons. Again, you can look in the guidance document on where you could consider using rapid testing, but not for your symptomatic patients. Next slide. So these are the two links that I've already posted, the guidance update and also to the specimen types for COVID-19 testing by patient characteristic, which speaks to that second question. The links are already in the chat. Next slide. So this is what I highlighted first. And again, antigen point of care testing, not for use in people with symptomatic infections, individuals with a known contact case or an outbreak. Next slide. So I know this sounds like motherhood and apple pie, but unfortunately, we do have a number of people who have gotten quite sick and have coded in some of the COVID assessment clinics. And so just a reminder for your staff, if people are calling your office, remind them if anybody has severe difficulty breathing, chest pain, altered level of consciousness or drowsiness, the appropriate place for them to go is the nearest emergency department. And then on the next slide, same thing. For children, these are the things that your staff should be. If somebody in your office is doing triage on the phone, it's not to a COVID assessment center. If any child has any of the following signs and symptoms, they should be going to the closest emergency department. Next slide. So what we have sent out, and some of you may have already seen it, though it was sent out late yesterday, and so you may not see it till at some point today. I've sent out a letter with this table along with Sasha Batcha. And this is really to think about, where you are in the province with what your access is to assessment centers and what kind of practice you work in. And so if you work in a practice where there's really a small footprint, you really can't cohort your patients to see people who are symptomatic, and you have little ability or limited ability to coordinate the transport of swabs to labs. Hopefully you have access in your community to a COVID assessment center, so you can direct your patients to a COVID assessment center and then follow up with them. And so I'll give you an example that I had a family member who, for whatever reason, had a 4-day history of significant fever, 39.5 and cough. They took 4 days to get swabbed. Thankfully, they don't live with me. And they're COVID negative, but they did follow up the next day, or actually the same day that they got their COVID swab. I think they got their COVID swab at 10 o'clock in the morning. they were able to call their primary care provider and say, listen, I've had a COVID swab, these are my symptoms, and the primary care provider saw them in the office. If you're working in a large practice, co-located providers, maybe a bit of additional support, large footprint, multiple doors, ground level access, so symptomatic patients aren't going to go up an elevator 8 floors. You could consider seeing these patients in your office. Again, if you have access to COVID testing in the community, it's not a you should. It's if you want to do it, that's great. And then what we have seen both, and we'll post some resources in the chat, both in Toronto and in the Golden Horseshoe, a number of the community assessment centers have now become cough, cold, and flu clinics, both for adults and children. And really that's because the communities felt that we needed to have a stopgap measure for people who didn't have access to primary care, or the primary care providers have told them locally that they need somewhere centrally to see patients who may have influenza-like illness. Again, I think the message should be, patients should call their office first. To the point of some of the questions in the chat, sometimes you can make figure out what a diagnosis is, and people don't need a COVID test. I should speak maybe because it is confusing with the school guidance. Some school boards have included runny nose in the guidance and others haven't. And that's why you see the confusion over whether or not that's a symptom or not a symptom. Obviously, it's up to an individual school board to decide if they're going to keep a child home with a runny nose. But I think that if a child has a runny nose for a day and they call your office and the next day they don't have a runny nose, and they're 7 years old, you may decide that in fact they don't need a COVID swab. So I do think it's important that people do get triaged first by primary care with the stopgap of having ILI assessment clinics in the community. So we'll post this in the chat as well as the Toronto and Golden Horseshoe resources. I think most of us can expect through our local Ontario Health region getting a list of the assessment clinics as well as any ILI assessment centers that are being opened up. And I'll take questions if there's any.
Thanks so much, David. Yeah, lots of chatter in the chat, and I think there's some follow-up questions. So one follow-up question that I've seen emerging is just the timing of the testing for COVID before you bring them into the office. So they have symptoms. When should you recommend they get the COVID test? And then how long do you have to wait for after the negative COVID test to bring them in the office? Partly, I think people are reflecting on experiences where the COVID test initially came back negative, but then it turned positive. So I don't know if you or others.
I was going to say maybe Allison and Jeff, especially with Delta being a different beast. I think the answer for Delta may be different than the answer was a year ago. So maybe I'll let Allison or Jeff take that.
I think my understanding of it is that if you're symptomatic, you should be shedding, right? And I think the question is right now, it's like, how long before you're symptomatic are you shedding? And if you're shedding, then your test should come back positive. So if someone's symptomatic and you test as soon as as soon as you're symptomatic, it should be coming back positive. So if it's negative,
yeah, I think that's
yeah,
consistent with my own personal approach and the approach of my colleagues is when somebody is symptomatic, we recommend they get a test right away. They don't delay. And I will say in our own clinic, we are seeing patients who are symptomatic as well. But of course, if they are able to get a test and clear it and that's safe and then see us, that's even better. But you should be taking precautions whenever you're seeing anyone. And so that is then reducing the risk of transmission among your staff and other patients coming.
And maybe if I could, I just, David, I wanted to say how I thought that what Ontario Health has put out is really recognized two critical pieces. And one is that we're part of a system as family doctors. So it's recognizing that what public health is doing, what the OHTs are doing, all of that becomes part of our response. And so if you aren't connected with that, to do that, to reach out. And if you don't know who to reach out to, write us at the OCFP or David, or we can help you identify that so you know what the system is around you. And I think the other part was recognizing that practices are all different, so it's going to vary, but there is an opportunity as we lean into what Allison has said is going to be going on between now and March, lean into ways that we can safely support our patients with these symptomatic illnesses. We're going to have to find ways to do that. And I'm thinking back to Tara, some of the great speakers we've had before, right? Whether it was, we had Nilly talking about, swabbing people on her front steps of her office. We had Megan Stevenson talking about using that end of day as really a time where you could safely bring in people who might be screening positive. We had Carol Geller talking about vulnerable patients where they're seeing even symptomatic walk-in patients. So, I think it's a time to really, whether you're big or small, to be having those conversations as a practice with your team to figure out how can I participate in this in a way that's safe and serves my patients as well. So I appreciated how you laid that out as the guidance for the from OH.
Yeah, and Liz, what I'll do also, just so to make it easier for people, I will post the link, the email addresses for the VP clinicals for each of the regions. So if people feel that they don't know what the resources are for their region, that they can, and the VPs are all happy to respond to those emails. So if you live in the north and you're not sure what the resources are, you'll send Paul Preston an email and Paul will get back to you. So I'll post those momentarily in the chat as well.
Thanks so much, David. So yeah, some interesting perspectives from the chat where, I think Alan Grill is reminding us that the provincial screening tool suggests runny nose that doesn't resolve meets COVID eligibility. And so I will say that, I think it is on your clinical judgment whether you ask someone to get a COVID test. That's my understanding, but at the same time, I myself, and I think many of us have a very low threshold for testing. And I think that's appropriate given the situation we're at. I think a couple of people are saying, just how they are able to manage things. So, Sahil Goyal is saying that in his own office, he's seeing all negative COVID patients in the office, even if they have URTI symptoms, and they're very appreciative. I think Carrie Bernard is saying that, they're able to see symptomatic patients in the weekends because they have low volumes in a large space. Otherwise, they're trying to see symptomatic patients at the end of the day. I'll say in my own office, we often use basically an isolation, like we designated one room to be an isolation room. So as soon as somebody with symptoms comes in, we don't have them come at the end of the day, but they come in and they don't go in the waiting room, they go right to that room. So lots of different ways in which people are making it work for them. Alan Grill just pointed out though that some pediatricians in the GTA are not seeing folks with RTI without a negative COVID test, and so there's sort of a systems issue at play here as well. So people have asked, are we going to get access to these slides? I want to review them in detail. So for sure, they're going to be posted on our website along where all the slides are, and I posted that link in the chat. I think there's lots of really good resources and perspectives there as well. So I want to turn it over to Jeff shortly. I guess just before we turn it over to Jeff, I wanted to just make sure we answered some of the questions related to the antigen and antibody testing. So again, we are going to have someone come on next time to talk more about this, but I wonder if anybody's able to comment on the different rapid antigen tests that are available and what the test accuracy is, and the difference with antibody testing. So antigen testing, we know, is not for people who have symptoms, but does anybody here able to comment on the sort of sensitivity, specificity, and whether there are differences between brands?
Allison, are you able to comment? I'm not.
Yeah, I think, my read of it is there's a significant amount of variability in the literature about the performance of different brands, which makes it very hard to interpret. We do know that who does the rapid test matters, and that you do get more false positives if it's being done at home than if it's being done probably in a family physician's office, or if it's being done in a lab. We also, there's one test that looked pretty good that's just had a big recall because they got into trouble with some components of their test. So I think the answer at the moment is, of the tests that have been licensed by Health Canada and available in Ontario, there's nothing to pick that we can say definitively. It doesn't matter which test you're using. They're by no means perfect, but they're pretty good. And you just have to remember that they're not as sensitive as PCR testing. But if they may not be perfect from a specificity point of view, but almost always, if you get a positive test, it's going to be confirmed by PCR. So when you get a positive test, you need to take it seriously, no matter who's done it or what they're doing, or how tempted you are to say, "Oh, that might be a false positive." They need a PCR test, and you need to treat them if they're positive until you get confirmation.
Thanks, Allison. Yeah, my understanding is that they're not sensitive, but they're really quite specific, and so you might get false negatives, but generally you're not getting false positives. I'll say in one of my daughter's schools, they did rapid antigen testing for many months, and they did up 7,000 tests, and I think only one came back positive. There were no false positives out of 7,000 tests that were done among the schools. So I think really do take the positive seriously, but if it is negative, it's not a complete reassurance. I'm going to turn it over to you now, Jess. So Brian, I wonder if we can bring up Jeff's slides, because I think some of the remaining questions that haven't been answered really are about boosters. And I think in particular, people are concerned about themselves as healthcare workers, and given that there is also a healthcare worker shortage, and we need everyone on deck. But I know you're going to talk a little bit about is there waning immunity or not, and then we'll take those questions after.
Yeah, thanks, Tara. And before I get into this, I just want to make one comment about the whole seeing ILI patients. I mean, I think the thing to be careful about is I think we just need to remember that the most important thing is our PPE. The patient needs to wear a mask, we need to wear a mask, and that keeps everyone safe, all the time. And because sometimes, people may lie on the screening. I saw a patient, one of my colleagues' patients, a young guy who came unvaccinated, who came in because of wrist pain as his chief complaint. And after I assessed him about his wrist pain, he said, "Oh yeah, and by the way, I actually haven't been feeling well the past couple of days." And then I sent him over to the COVID assessment center to get tested. And of course, he came back positive. But fortunately, we were all wearing our masks, so it was okay. So I think the thing to keep in mind is that we may be worried about our patients who have ILI, but sometimes it's the patients who don't come in with ILI symptoms that are the ones who may actually be an issue. And so we just have to be alert at all times and just maintain vigilance. So now I'm going to get into my talk, where I'm going to just talk about some data on the question about waning of vaccine protection. And so the first slide here is data from the Pfizer's RCT, where they did longer term follow-up. This came out in mid-September. And so you can see at the bottom there, apologies, the numbers are a bit small, but on the very right-hand side, you can see the vaccine efficacy estimates after the second dose. So you can see, peaks at around 96%, 7 days to 2 months after the second dose. And then it drops slightly to 90% and then to 84% by 4 or more months after the second dose. So I just want you to remember those numbers, peaking at 96 and then dropping to 84 at 4 months after the second dose. Okay, next slide, please. So now I'm going to talk about a bunch of observational studies. So these are either test negative design studies or cohort design studies. And so this is from Kaiser Permanente in Southern California. And so in the upper graph, they're looking at infection as the outcome over time. And in the bottom, they're looking at hospitalization over time. So on the x-axis, you can see the number of months since receiving the second dose, so 1 to up to 5 months or more. And you can see clearly that the infection, the vaccine effectiveness against infection appears to go down to about 50% by about 5 months, or 60% at 4 to 5 months. Whereas hospitalization, it stays high at about 90%, and this is consistent across all age groups. Next slide. This is data from the UK, from Public Health England. So on the left, you'll see estimates for AstraZeneca vaccine. In the middle, you'll see the estimates for the Pfizer vaccine. And the right, you see the Moderna. And the top 3 are for symptomatic disease. The middle is hospitalization, and the bottom row is death. And so we'll focus on the Pfizer estimates. So if you look in the middle column, you can see that the Pfizer estimates are really high for all three outcomes, higher for hospitalization and death compared to symptomatic disease. There appears to be no waning against hospitalization or death. This is up to 20 weeks, so that's about 5 months. In the top, you can see there is some appears to be some waning against symptomatic disease. The black squares are against Delta, and then so those are the most relevant because Alpha is pretty much gone now. That's the circles. So you can see at the 5 months it's about about 70% according to this study, which used the test negative design. Okay, next slide, please. Now, data from Quebec, closer to home, we can see that estimates against infection and hospitalization are pretty flat all the way to 5 months or beyond. So in the orange, it's hospitalizations, and then in blue, it's infections. Next slide. In BC, you can see at the lower left, you can see over time, this is up to 16 weeks, so 4 months, you can see that the vaccine effectiveness against hospitalizations in orange is consistently high. For infections, it seems to have declined a bit from kind of the mid 90s down to maybe 80% or so. And the thing to keep in mind though, on the bottom right, you can see that they've presented vaccine effectiveness estimates by the interval between doses. So it's suggesting here that people who have a shorter interval between doses may be having a lower vaccine effectiveness compared to the people who've had longer intervals in between doses. However, I think you need to think of it as like, these two images on the bottom are kind of like mirror images of each other. The people who've had shorter intervals have had longer follow-up, and the people who had longer intervals between doses have had shorter amounts of follow-up. And so they might actually be the same, the same people who are having, high effectiveness or low effectiveness. It's just, I'll get to this when I get to the Ontario data. So next slide, please. So now we have the Ontario data, and this is data that, we've been using the data here at ICES, and on the left, we've got data for the mRNA vaccines combined. So here we have the x-axis is vaccine effectiveness. So if the further to the right is the better. And on the y-axis, the days since your last dose. And the gray bars are days since if you've only had one dose. And then the black bars are days since your second dose. So you can see that after your second dose, by 7 to 55 days, it's 94% vaccine effectiveness. This is against symptomatic infection, and then it stays at 92. And then by 112 days, which is 16 weeks, it drops to 83, and it stays consistent in the 80s all the way up to 32 weeks. So 224 days, 32 weeks, that's almost 8 months after the second dose. We're still seeing reasonably good vaccine effectiveness. So once again, this is for age 16 or older, symptomatic infection against any lineage. In the middle, you'll see the estimates against AstraZeneca, in the high 80s. After the second dose. We don't have a lot of data after, like 16 weeks there. And on the right, people who received one dose of AstraZeneca and one dose of mRNA, it's comparable to people who received 2 doses of mRNA, vaccine effectiveness estimates in the 90s. Okay, next slide, please. So this is against Delta, which is like now, all COVID now is basically Delta. And you can see the estimates are virtually identical as against any lineage. So that's good news. It just suggests that there's no decrease in vaccine effectiveness against Delta that we're seeing here in Ontario. Next slide. Now we're moving on to severe outcomes. So this is hospitalization or death. And you can see on the left graph there that all the estimates are in the 90s. So staying really high all the way out to 32 weeks post the second dose. And next, this is the next slide, please, Brian. Yeah, this is against Delta. So you can see once again, VE estimates are all in the 90s against Delta. And sorry, I forgot to mention that AstraZeneca also very good against severe outcomes. So I think all the vaccines are very effective against severe outcomes, and the vaccine effectiveness seems to be holding up really well, even up to 32 weeks. Next slide. Oh, sorry. Before we move on, I just wanted to point out, so remember in the RCT, they had estimates of 90-something%, initially, and then it dropped to 80-something% by 4 months. And so I think our data are consistent with RCT data. And the thing is with these observational studies, you're never quite sure. There's lots of things that can go into it. You may be underestimating or overestimating. So it's hard to say, whether those other studies are right or wrong. Maybe there's something going on there, like how they're doing their testing or other factors, other public health measures, like all sorts of things that can be influencing these estimates. So you may be seeing lots of inconsistency in the data out there on whether there is truly waning or not. At least here in Ontario, with the data that we have here, using at least the test negative design, and we've also used a cohort design as well, we're seeing not a whole lot of waning in our data. Okay, next slide. So here we've broken it out by age. Oh, sorry, back one. We've broken out by age group. So you can see on the right-hand side, 16 to 69. On the left-hand side is 70 years or older. And you can see maybe there's a suggestion of some waning for those who are over 70 at 6 months. That's 168 days. That's 24 weeks. So maybe it's a bit lower. I think we just need a little bit more data to be a bit more confident. Is that really lower, or is it just a wide confidence interval there? But definitely for those 16 to 69, it's pretty consistent. They're 84, and in the previous graphs you saw that even up to 32 weeks it was staying in the 80s. Okay, next slide, please. Yeah, so this is against severe outcomes. It's still pretty high whether you're in the younger age group or the older age group. So I think that's quite reassuring that we're not seeing significant decreases in VE. This is for, keep in mind, this is community dwelling older adults. Although we're at ICS, we're not able to identify retirement home residents. So this includes retirement home residents as well. So that's good news. Okay, if you can move to the next slide, I think. Oh yeah. So now we move on to the issue of the question of what, whether it's a dosing interval is important. And so what we've done here is we've grouped just the people who've had their the interval between dose 1 and dose 2 as less than 35 days. So if you had your the interval less than 5 weeks, you're included in this group, and we plotted out the vaccine effectiveness over time. And you can see it does decrease from kind of the low 90s. At the 5 month mark, it did go down to like 75, but then it appeared to go back up to 80% at 6 months and beyond. I think that the 5 month is just a little bit of aberration. You see that wide confidence interval there. If you can hit next, please, Brian. Then you have the group that had an interval of 5 to 7 weeks, which shows slight decrease. And then next, please. You can see the blue line, which is pretty similar to the yellow line. Maybe there's some separation at the 4 month mark, and the next one finally in the green. So at 12 weeks or more for the interval, it's like identical to the blue line. So there is maybe some suggestion that there is a slight lower effectiveness in those who had a shorter interval, in the long run. I think we just need more data to be more confident. I think in the next month or two, the blue line and the green line will get extended, and we can see if there really is separation between those who had longer intervals versus those who had shorter intervals. I think the thing to keep in mind is that the people who had the really short intervals, they're the people who got vaccinated back in January and February. And if you remember, it was like at that time it was like healthcare workers and retirement home residents who were getting the vaccine at that time. And they had a short dosing interval, and for various reasons, they may have higher or lower vaccine effectiveness than the general population. They may be at higher risk because of exposure, or maybe they're at lower risk because they're more careful about PPE and following other public health measures. So I think we're going to be doing more analyses and looking into this further. Okay, I think that's it for my slides. Next slide, please. Oh, yes, sorry. And this is against severe outcomes. We're seeing that regardless of whether you had a short interval or a long interval, you still have a very high vaccine effectiveness against severe outcomes. Okay, I think that's it for me. Oh, sorry, one last slide.
You've got one more slide.
Yeah, sorry. Yeah. So I think the summary is that most studies are showing minimal waning of protection against severe outcomes. I think there's good consensus about that. So I think these vaccines are very effective in the long run against severe outcomes. I think there's some studies are showing some waning of vaccine protection against infection, whether symptomatic infection or any infection, and the extent of the waning seems to vary by study. So I think we just need to wait for more studies to come out to see, where the consensus is, hopefully. Based on the Ontario data, I think there's a suggestion that the very high VE for the mRNA vaccines, even 32 plus weeks out after dose 2, with only slight waning against infection. Maybe there's more so for older adults, but not against severe outcomes. So, based on this, I think boosters don't appear to be needed for the general population at this time. I mean, I think we do need third doses for the very high risk people, like the immunocompromised and long-term care residents. But I think for the general population and including the healthcare workers, I mean, I think the argument for healthcare workers to get a booster, I've heard people are saying, well, maybe it'll help to reduce transmission to patients, and so that might be an argument. I think we might need more data, whether to show if that is a necessary strategy. I think what we do know right now is that there's so many places in the world that haven't yet had access to vaccine. And I think, it actually is probably in our best interest to get vaccines to those countries so that they don't, so that new variants don't emerge that come back to bite us here, rather than, having us go from, 80% vaccine effectiveness against infection to 90, something percent again, to use up those, how many, tens of millions of doses, for all of Canada. So that's it for me.
Thanks, Jeff, and thanks very much for reminding us about the importance of global vaccine equity is really the way to move forward in ending the pandemic. I think I'm just going to, reread Alan Grohl's question here, because I think we've touched on it, but I think, so he asked, do you think healthcare workers should get boosters in Ontario to protect human health resources, as opposed to worry about us getting breakthrough infections? And this is not just for you, Jeff, I think this is for any of the panelists. I will say he also added in the chat that Israel showed reduction of severe symptomatic cases with boosters for those over 60, an article published in the New England Journal. So I wonder if anybody wants to comment on those questions.
I think the thing to keep in mind is that you have to look at what's going on in your jurisdiction, right? So if you have a vaccine effectiveness of like 90%, and you've got you're at a peak of an epidemic, you're still going to see lots of breakthrough infections, right? Versus if you have low incidence. So it's kind of like this, there's always that question about relative risk reduction versus absolute risk reduction, right? The relative risk reduction stays the same. Let's say it's 90% whether you're in Ontario or you're in Israel. But if you have low incidence like we do right now in Ontario because of all the public health measures, our masks and everything, I think we're able to get away, it's okay. Versus in Israel, if they've got a raging, wave going on, that vaccine effectiveness of 90% will lead to a lot of, breakthrough cases, just because, there's just the force of infection. There's just so many cases out there that there will be breakthrough cases. So I don't know if that answers your question, Alan.
Yeah, I think that's great. I mean, I think someone else also asked if whether there is effectiveness data over time for people with mixed doses. I think most of what you presented were people who got the same dose of vaccine, were doubly vaccinated with the same vaccine.
Yeah, I mean, what I presented on the left with the mRNA vaccines, it was either the 2 Pfizer, 2 Moderna, or Pfizer then Moderna, and vice versa. I think the thing is with the mixed as an AstraZeneca mRNA, there just hasn't been enough follow-up time on the people who got it, because remember when we started doing that was a lot later, right? We were giving the AstraZeneca in April, and then we said, oh no, we should stop using AstraZeneca. We should switch the mRNA for them. I think it was June or something like that. So we just don't have that much follow-up time on them yet. That's why we're only able to have 2 bars. Where we actually were able to generate good estimates.
That being said, I would just add the FDA is actually looking at mixed dosing next week. And so it'll be interesting to see what the FDA recommends. And it obviously is going to impact, I think there were some questions in the chat about people who got mixed dosing and whether or not they would be eligible for a booster so that they don't have any travel restrictions. So I think it'll be the next 10 days or so, it'll be an interesting signal from the FDA.
I do think that everything we've seen with immunogenicity, everything we know about these vaccines tells us that there is absolutely no issue with mixing vaccines. And we are we are learning that immunogenicity and antibody production is significantly correlated with outcomes. And on that scale, the best combination to get actually is first dose AstraZeneca, second dose Moderna. So everybody who is suffering from travel reasons because they got first dose AstraZeneca and second dose Moderna should be reassured that they've actually probably got better protection than all the rest of us who got anything else. But it is really frustrating that the Americans will not recognize. Mind you, we're not that good at recognizing other vaccines in Canada either. So there is an element of the pot calling the kettle black here.
Yeah, so I mean, we don't have answers to when will healthcare workers get their doses in Canada, but I hopefully you feel reassured about some of the data that's coming out today and putting that need in perspective. And I think also just Jeff was very humble and I don't know if he was explicit that he actually led the study, but the data he's showing you was data that he actually led as a principal investigator. So thank you, Jeff, for all that work you're doing behind the scenes. I do want to remind folks that these are the reasons that you can get a third dose in Ontario today. Next slide. I know that for many of us, it was hard to actually understand kind of or know like what all the medications were that made you eligible in those categories because they gave just the very top category name. So this guidance came out yesterday actually from the Ministry of Health, and it goes into more detail. Still not a comprehensive list, but it has many of the most common medications listed here that would qualify you for a third dose. Next slide. I also just wanted to share a shout out to our own pharmacist team at where I work at St. Mike's, who put together this Google Doc a couple of weeks ago, where they list actually in a bit more detail what some of the medications are in each of those categories that would make you eligible for the third dose. So that's also a terrific resource that we were happy to share. Next slide. So actually, I'm going to just go to the second last slide now, Brian, and actually one further back. So just wanted to let people know, I know people are really trying to get their unvaccinated people who are unvaccinated, convince them to get a vaccine. And these are a couple of just resources to highlight. This is a new line that's been put out by Sick Kids, a vaccine consult service. So if you have questions, your patients have questions, they can just call this line directly. And I think it's, they have quite a few appointments, and I think so far it's been going well. Next slide. And then if you haven't, told your patients about the Vax clinic, please do. This is, sometimes some of us have done what we feel like we can in terms of counseling, and sometimes you feel, oh, maybe it would be good if someone else kind of gave it a shot in terms of maybe they have a different way of explaining or can take more time. I understand they're, spending 40, 45 minutes with patients on the phone, really going through all of their concerns, and that they actually have a really good rate of convincing folks. And we're actually going to try and hear from the medical director of this clinic at one of our upcoming webinars as well. So more on that. Next slide. So just want to say thank you to everybody. I urge you to please fill out the evaluation that we're going to send you. We've added 3 questions just to really hone in on what it is that you want to hear about in our upcoming sessions. We've also changed back to a every 2-week schedule. We realize that there is actually a lot going on in terms of COVID still, and we need to, and people have questions, and we have a need to communicate sort of evolving guidance and practice and policy. Our next session, we are going to talk more about testing. Hopefully we'll talk more about convincing people who are still resistant to vaccination. But what else do you want to hear about? So fill out the evaluation and let us know. We have all of our slides in the Q&A on our website, and we've posted the link there. I want to give a huge thanks to our panelists today. They are all amazing and doing amazing work behind the scenes. So not only did they give their time today, but they're doing amazing work behind the scenes, generating research, generating guidance, and helping develop policy that helps to keep us all safe and responding to this crisis. And thanks to you for all that you continue to do. I always learn a lot from the chat and from what you share. Thank you, and see you in a couple of weeks.